I want that to be the first thing on the recording.
Sounds like something out of a movie, Tom. Okay. So do we want to wait for Bill or anybody, or do we want to start?
You said Bill was going to be... Yeah.
We only have Colleen until 2. Is that right, Colleen?
Do I what?
We only have you until 2, right?
Let me just look. I know that. Let me just look if I can get to the 2 o'clock late. I will try not to, but in general, yes, that is my time constraint.
Okay, so Sarah, are you thinking we should just go ahead and start and let people join us? Does that sound right to you?
Yeah.
Okay.
Unless you. Yeah.
Well, we're really glad that the. What? You know what? On the phone, I couldn't hear that.
Oh, that was me making an offhand comment, so you can ignore me.
Okay. Okay. All right, we're going to turn it over to Sarah and Colleen.
So
we're very grateful you're here.
Oh, thanks for having us. I miss this group. I wish I could be here more. I feel terrible about it. One thing, just in terms of logistics. So, am I sharing my screen and then I'm driving from my screen, or are you guys?
So you're sharing your screen.
Okay. All right. Then can I just close my Skype so nobody has to see my staff saying no? Okay. And let me just shut my email.
Email if you want
Nobody wants to see my staff saying, "You're late, get out." Okay. So, fun. All right. So, Sarah, do you want to do opening? Do you want me to do opening? I know the detail parts I'm talking about, but how do you want to go through that, Sarah?
I'll do kind of a quick opening, and then if you want to take over with the work group charge.
Sure.
Because we had Elena Rivera from Children's Institute and I had come and spoken with this group quite a lot some time ago when we were first embarking on this work, and it was actually before Colleen had joined the team. And so just to give background for everybody, there'd really been an interest in having a CCO incentive measure around kindergarten readiness. And so we had not really taken off on that work until, luckily for us, Children's Institute offered to partner with us on that endeavor. And the collaboration with them has been, their role has been really invaluable. Through them, we were able to bring Colleen on board, and they really helped us as the kind of the health sector representative to better coordinate and get feedback, et cetera, and link with early learning. It's really been a great partnership. And so all of this work started because the Metrics and Scoring Committee said we'd really like to have an incentive measure behind this, and just to give everybody an idea of what that means. So our last payment to the 15 CCOs in operation was just under $100,000. And we've had an independent evaluation of our program by the Center for Healthcare, I can never remember, CHCS at OHSU, and I can never remember what the acronym stands for. It's John McConnell's shop, which found that we monitor the health system, the CCOs, on lots of things, but the things that they really focus on are those that have the incentive dollars behind them. So it's a very, very rich carrot to have. And so with that, Colleen, I will put it over to you, and then I can let me know when you want me to jump in.
Sure. So as you guys heard, there was this kind of we want to have an incentive metric on kindergarten readiness, but there wasn't really clarity on like what that meant and how would that get operationalized and what kind of metric would fit within the kind of the framework of metrics and scoring. And so in order to kind of make sure that this work was done intentionally, collaboratively, and built off kind of the ideas of various people across the sectors. Uh-oh, I just lost my, that's okay.
That was me.
Kind of the way that, Children's Institute kind of thought about kind of how to make sure that that could happen was to create a work group, and that work group would kind of help us refine and think about the metrics that might ultimately be presented. I think one of the key things about that work group is that we started really conceptually and importantly based in some frameworks that I think are helpful for early learning as well, and then kind of narrowed down to the primary goals. So the work group charge was really to kind of very specifically think about that there's a lot of things that, and a lot of different stakeholders that play a role in kindergarten readiness. The early learning system knows that extremely well. And so what we were trying to think about is like, how do we get the healthcare system to do a better job with their specific piece of the pie? And how do we start with like making sure that they do that work well, knowing that, you know, there's still all the other pieces of pie? And how do we use a construct that kind of fits within that pie so that we're not kind of thinking or using different terms that couldn't be applied across different sectors, given that it is going to take a cross-sector work in order for us to help children be ready for kindergarten. And so the charge of this work group is specific to that piece of the pie, and then it was to recommend one or more health system quality measures that do three things. One is that they drive health system behavior change, quality improvement, and investment. Two is that they catalyze cross-sector collective action that's needed for kindergarten readiness. And three, it has to fit in the square peg, which is the metrics program. So when we go through kind of like our conceptual framework and where the metrics landed, a lot of that is kind of anchored to what the charge of the group was. So if you're doing like a population health metric where you're kind of trying to track at a population level, which is a lot of the metrics we've been thinking about in this group, that can be a very different goal than a metric that you're using to kind of incentivize and drive the kinds of things we're talking about. And so the kind of parameters of what these metrics were meant to do is really important. And what we'll try to do is kind of share with you the process that we use to make sure that we were honoring the big picture goal, but also making sure that whatever we proposed kind of fit within the square peg, which was the metrics and scoring incentive program. All right, sorry, I have to see if So one of the great things that Children's Institute did was really make sure that the work group members included a wide array of different people. I know Children's Institute has presented to a bunch of different people on this, but I think it's important to know that there were CCO representatives, pediatric care providers, early learning hubs and early learning programs, behavioral health. There was people with quality measurement expertise, and then representatives of families and children used with special health care needs. And then, as Sarah mentioned, this has been just a super fun collaboration between Children's Institute, the Oregon Health Authority, and then me from the Oregon Pediatric Improvement Partnership, and Diana Bianco from Artemis Consulting, who helped facilitate the work group. And I really think all four of us kind of brought different knowledge base and different expertise that I think was really helpful in kind of facilitating our process and identifying metrics that could work across stakeholders. So in terms of our process, you know, we had a pretty short timeline to come up with a pretty intense proposal for a concept that really hadn't been detailed defined in terms of like, what do we mean by metrics focused on kindergarten readiness that could be played out in a healthcare system? So we began with like making sure that we had a construct and definitions so that we had clarity at the beginning before we started filling in and thinking about metrics that would work. So March through May, there was really important background work. There was a really important and heavy focus on making sure that whatever we did was aligned with what families told us was important. And so Children's Institute contracted with some folks to do an amazing family focus group, and I think one of our members on this group was part of that team. And then we really had to first start with, like, people are talking about a metric of health aspects of kindergarten readiness, but before I could help them think about which metrics might be options for us to consider, we didn't have clarity on like what we were talking about. And so when you don't have clarity, in order to fill a metric, you first have to develop a conceptual framework. And so that's what we did, is we developed a conceptual framework for health aspects of kindergarten readiness, and then developed, before we even started to look at metrics, what would be the criteria by which we would assess metrics and whether they met our big picture goal. And I do a lot of measurement work, and I do a lot of work with broad groups, and often people just want to start at like, what metrics do we have, and not start at the like conceptual framework component and the criteria component. And so I think that was one really good heavy strength of this process, is that we started with the kind of the house and what we wanted to make sure that the house had, and then thought about what metrics might fill that house. And so June through August, we really kind of then identified, given that conceptual framework, where would this group say there were priority areas that we should focus on looking at whether there are metrics and assessing whether the available metrics would be good proposals to set forth. We then reviewed and assessed those metrics using our measure criteria. We discussed new metric development, although we wanted these metrics to be able to be applied in the next 3 years. And so we had to kind of think about feasibility related to that in terms of which metrics could be developed in that time period and which metrics maybe couldn't. And so based on a lot of that work that happened over the summer, the Health Aspects of Kindergarten Readiness Work Group helped us narrow down to 13 priority metrics that kind of fit within our framework and had a high enough score on our measure criteria that we thought they were important to keep in the game. And then we really just thought a lot about strategy. So again, if you don't think about a successful strategy, you can design a perfect measurement plan that nobody implements because it doesn't fit within the framework of implementation. So our measurement strategy was really had a couple parts of, one, how do we make sure that this measurement strategy aligns with our goals that we articulated in spring, but also fit within the square peg of the metrics and scoring program. So one kind of thing for you guys to think about in terms of measuring success in the early learning system is the metrics that we identified aren't necessarily the only things that we think the healthcare system should do in playing a role in making sure children are ready for kindergarten readiness. The metrics that are at the end that ended up being part of our proposal are the metrics that we thought fit best and were ready to go and could galvanize momentum within the metrics and scoring incentive program. And so that is a very specific lever that is within coordinated care organizations, and it's one that has a lot of money tied to it and has a lot of options because of that money and measurement, but it's not the only one. And so when you look through it and you say, well, why aren't you saying that CCO should focus on X, Y, Z? That wasn't the scope of this work group, was identifying what the healthcare system's role is overall and metrics overall that would track the role. The goal of the work group was to identify specific metrics that could be used to put into the incentive metric program in the near term, in the next 1 to 3 years, in order to galvanize momentum. So if you have questions along the way, that framework is actually a really important one to understand in terms of our parameters. So the first thing we had to do is say, well, what do we mean by kindergarten readiness? And so we made sure to not use any definition that was from the healthcare environment, but instead used information that was from the early learning environment. And we wanted to align with the early learning system. And so we kind of adopted at a broad level the definition of kindergarten readiness that the Early Learning Council created in the strategic plan, that all children arrive at kindergarten with skills and experiences and supports to succeed. And then we had a couple of taglines that you'll see on this slide that were really important in terms of key things that the group wanted us to kind of understand. So again, in trying to make sure that this work translated across multiple sectors, this was an intentional goal of ours, is to kind of use a broad early learning based definition and then think about, okay, well then what is the healthcare system's role? So then the second thing that was really important is if we were going to be trying to develop, given this definition, that's a really big definition. So right from the start, we knew, it's not going to be one metric, because in order to think about, one, what the healthcare system's role is in making this happen, you would obviously know the healthcare system could play a lot of different roles. And so in order for us to kind of really think about, what's a conceptual framework by which we might look and see what metrics do we already have, what are new metrics, how do we prioritize which metrics we propose, how do we not propose a 14 or 18-part metric because that won't work? We first had to start with the conceptual framework. And so as we talked about in this group before, we intentionally made sure that the conceptual framework is one that could be applied and used by different settings so that you could think about, okay, well, early learning hubs, what domains specific to early learning hubs could you play in terms of addressing? And so I'm loving the alignment in terms of measuring success, but it was partly the reason why Sarah and I were noting that, because we found that to be a really valuable part of our work. So the domains on the left that are in white are kind of one of the common questions people say is well, what do you mean by kindergarten readiness? We give that definition. And then they say, well, how do you know a kid is ready for kindergarten? And so the domains that are here are domains of health that impact a child's kindergarten readiness. So they're domains of what the early learning field overall has told us kids need in order to be ready. The bolds are really important because the bolds are the populations by which we might think about specific metrics. So as a measurement person, for me, the bolds are important because they are the denominator for the metric, where the grays are the numerators of the metric in terms of like, for whom, the dark bold, are we looking at care, and then what are we looking at whether they received it. So we made sure that we used kind of broad child definition and broke it out into the different components that we saw across a lot of different early learning structures. So child's physical, perceptual, and motor development, which would include nutrition, vision, and dental, social emotional development, cognitive language and literacy development, and then family function and capacity. And you'll see family lower on. The reason we needed to have family in two different ways is family here would be ways in which you could measure whether family function and capacity was addressed for children. So the denominator for this family function and capacity would be publicly insured children, because again, we're going to a CCO incentive metric. And then I've done a lot of work focused on children with special healthcare needs. And if you don't call them out as a specific population, often people think, well, they're part of the full population. So if we do it for the full population, it'll happen for children with special healthcare needs. And the literature and research actually just doesn't show that. And there are specific things that are important for children with special healthcare needs in terms of preparing them for kindergarten readiness. And so we wanted to call out that population. And then within the coordinated care organizations, they do play a role in terms of parent caregiver health. And so we wanted to call that out as a potential denominator for a metric, and really called out two different groups. One is prenatal, so mothers, and potential roles the healthcare system could play in addressing prenatal health in the mom. And then the second would be addressing health in the parent caregiver that's been shown to impact a child's kindergarten readiness. So again, that left side is not specific to healthcare at all. It's specific to the kinds of things that we know impact a child's ability to be ready for kindergarten. On the right, the gray and the blue are really like trying to think through, if we're saying that the healthcare system has a role, what are the buckets of things that the healthcare system does that could impact a child's kindergarten readiness? So the gray and the blue are specific to healthcare, and what we were trying to do was come up with a conceptual framework that really articulated the different roles that a healthcare system could play. So promotion, prevention, screening, and early detection, follow-up to address risks identified, care coordination and integration, and family-centered care. The gray are all meant to kind of help us identify and think about what person or child or parent level metrics we could use to identify whether those kinds of things happened. But what we realized is that there was a lot that needed to happen at the system level, the CCO level, that would really impact these domains of health, but yet there's not a child level metric available, or we really need to start first with some system level activities. And so that was the purpose of the far right column, was to kind of open and expand our thinking that we may consider metrics that the denominator is not children or adults, but that the denominator may be CCOs, and whether CCOs are doing system level activities that could kind of impact and address the policy, payment barriers and practice level barriers that we all, from the work group point of view, were pretty aware of. So this was like a really important foundational step for us, because everything we did from here on out was an anchor to our conceptual framework of what metrics are already in the incentive program, what columns are addressed, what columns aren't addressed. It also helped us kind of think about and prioritize where, given that we had limited metrics, we couldn't propose a metric for every cell in this table. That would not be feasible. How do we prioritize which metrics we pick? And so later on, when I show you kind of a visual of those 13 metrics we picked, we made sure to note in the visual where they fell in terms of the domains of specific healthcare services, because that was important, because you will see that the current metrics are heavily weighted in this. And if we believe that the healthcare system has a role, So if we believe that the healthcare system has a role that's beyond promotion, prevention, screening, and early detection, which our work group did, then you would want to make sure that you at least have some metrics that address other domains in this conceptual framework. So what we did is we then looked at the current CCO incentive metrics by the conceptual framework. And this is, again, an important context for you of we needed to take that into account because the CCO incentive metric is a limited number of metrics. Like you don't get to pick 100 metrics. Right now the metric set is 19. And so if we were thinking about proposing a metric to go into that set, we needed to think about what was already in that set. And given we don't get to propose a ton, that was part of our strategy of thinking about where there were gaps between what is currently measured incentivized and where we know there are important opportunities. So as I mentioned, all of the current incentive metrics with the exception of assessment for kids in DHS custody are focused on promotion, prevention, screening, and early detection. You'll see that there are no metrics focused on follow-up to address risks identified. I think the assessment for kids in DHS custody is a fantastic measure for a relatively small group of kids, and so I think there's opportunities around care coordination and integration. And there were no metrics that were specific to 0 to 6 and family-centered care and optimizing interactions. So then what we did is we decided, okay, so we're going to start looking at metrics that we might propose to fill those gaps. How do we decide whether the metric is a good metric or not? And again, having done measurement work for 20 years, I think it's really important to start first with, like, what's your measure criteria? Because if you don't do that, you will quickly go into, like, what can you measure, or what is easy to measure, what is already there to measure, or what is one person individually like to measure. And so the measure criteria, we spent time at the very beginning, before we even considered metrics, clarifying those measure criteria. And then we intentionally used the measure criteria throughout the process to say a good measure by concept would meet more of these criteria. So the first set of criteria weren't criteria that we used to assess a metric, but we didn't even look at a metric unless it fit our criteria. So again, when you look at some of the metrics that Measuring Success has identified, some of those wouldn't even be eligible for us to look at because they don't fit our criteria. They can't be reported at a CCO in a 12-month time period. They don't have technical specifications that are reliable and valid at a CCO level. They may not be feasible to collect at a CCO level. Or they may not be attainable. One of the goals of the incentive program is that, like, they have to be able to improve on it in a year. For some of the big picture goals we have, it wouldn't be fair to expect a CCO to turn around an improvement in a year. Then we identified criteria to assess individual metrics. And I won't walk through all of these criteria, but there are ways to help us kind of understand, given the definition and given our work group charge, how would we know whether this metric meets that goal? And so we went through a number of iterations and came up with these different criteria that helped us kind of understand. And later on, you're going to see a number next to the metrics. That number is, on average, across our committee, the mean rating of whether that metric met these individual criteria. So a higher number, so there's 13, a higher number would mean that on average, the work group overall said it has evidence-based, it has outcome, actionable, that they said yes to more of these bullets. And then we had to create a set of criteria around if we have more than one metric, which we did, we ended up with a 4-part proposal.
So just a quick clarification question.
Sure.
So like, were they asked to sort of score each of them like on a 1 to 4 scale or something like that?
No, it was a really...
Yes, no.
Oh, just yes, okay, yes, no, okay.
Yeah.
Okay.
That would be actually fun to do, but probably really messy.
Okay.
And then
for no particular reason, I was interested in how you scored it, so.
Yes, and what I really liked about the process, David, is we, the staff, gave them information about the metric. We gave them the numerator, denominator. We told them the current quality. We told them our staff's perceptions of whether the metric met those, like, information that would inform them, because I don't expect a mental health provider to understand whether this is a clinical recommendation for primary care providers. So we tried to give them relevant information. Then what the work group did is they went through on SurveyMonkey and clicked whether they thought the metric met each one of these 13. And then we shared the results at a group level during the meeting. And then we asked people, like, if there were metrics if there was a metric that certain criteria, it didn't look like a majority of the work group agreed, we would have a conversation and say, it looks like 6 of you said yes and 6 of you said no. People who said yes, why did you say yes? People who said no, why did you say no? And that conversation was actually really rich and helpful. And then when after that conversation, then we allowed them to assess the measure again, and we used that as the final score of what the work group thought. So it was a way to kind of allow for the individual voice and the individual expertise, but to also generate and stimulate the across group voice and across group expertise and learning before we came up with the final, like, this is your final assessment of the measure. And then we had to do it for the composite. And I remember like a couple little sideways looks at me when I said, we need to have a composite measure criteria. Again, having developed composite measure criteria, they are often different than your individual metric criteria. So as we were thinking through, when we landed on our 4-part criteria, we went through and thought, okay, this set of metrics, does it fit? Does it meet these 4 different criteria? Is it parsimonious and limited? Do the metrics in combination measure the desired outcome? Do they utilize various data sources? And does it include measures with the most transformative potential? And that's where we really use that measure criteria score to help us understand, like, well, this is what the group said in terms of higher weight, but then it was also something that we used qualitatively in terms of facilitating a work group conversation. So then what we did is we went back to that shell of the conceptual framework. So you're going to hear me say over and over again, if you're developing metrics or a measurement set, like, use a conceptual framework first. Then we went through, which I love that we've done for measuring success. Then we went through and just asked people globally, like, what would you want?
Oh, you're
Hello?
back.
Oh,
You're
You're back. Can you hear us?
okay. I was like, oh gosh, they don't think this process was, it said you're not valid. And I was like, okay. That was pretty good. So we went through and just asked people topics, like, you people, we recruited all these different people. What do you think is important for us to look and see whether there is a metric? And again, it had to be a metric, not just like, is there a metric, but is there a metric that fits this first required criteria? So I will tell you, there were a lot of things that, like, the concept is right, but there's not a metric that can be applied within the CCO incentive metric program and fits these 4 criteria. So that's one big question we get asked a lot. It's like, well, why didn't you think about using the National Survey of Children's Health metric on this? And it's like, well, the National Survey of Children's Health can't be reported at a CCO level. There's no specifications at the CCO level. We don't have any data that it could be improved in a 12 months. And so that's just a really important filter when you see some of the metrics that we considered and then the metrics we landed on. If they fell out, that's where they fell out. But this is in general where the group told us, go look for metrics. So we went and looked for metrics related to these topic areas. And then we presented them kind of all the metrics that they identified. We assessed them. And based on that process, which was a lot of time, but I'm trying to stick into our time frame, a lot of time and lack of sleep, we kind of landed on, from a work group, we narrowed down to, if we're really kind of thinking about the short and long-term goal, that the health system, that these metrics drive health system behavior change and investments that contribute to kindergarten readiness and cross-sector efforts that far right our long-term goal. And looking at all of the metrics and thinking about which ones could be implemented in the near term. And near term is like in the next 3 years, which I just accepted is like, that's fast in a healthcare incentive metric program world. So which metrics could be implemented, approved, and potentially be adopted for 2020? That would be the earliest. Which metrics could be proposed and approved in 2019 and then adopted in 2021? And which metrics could be proposed and approved in 2022? And then on the far right are additional metrics that were identified that need development. They're either new metrics, and so the development work to make them possible and make them feasible for adoption in an incentive metric program is more than 3 years, or there are existing metrics that would need a lot of development to apply them as an incentive metric program. So this looks like a very busy chart, but the things that are important to recognize is shapes and colors matter. So the shapes align with the columns. So remember I told you, like, we wanted to make sure we were being really thoughtful about aligning, making sure that we filled the column. The shapes correlate to those columns. So the rectangle, for example, is that first column, and the circle, for example, is the second column.
Can you go back to the second
colors,
so you know those match up? Can you go back to the other chart?
Sure. This
I'm just trying to. Okay.
I have a table that I know what you want, David, and I'll send you a table. I have a color-coded table. You and I think similar, David, so I will help you with my table. Sarah, we need to send him the table that has current incentive metrics, topics identified, and metrics that we were able to assess, and then metrics proposed. So we have a 4-part.
The shape corresponds to the first column. I couldn't remember what the first column was in the second column.
Oh, sorry. Promotion, prevention, and early detection. And then the second column. And then if it addressed multiple domains, then we kind of created our fun little shape of multiple domains. So again, why is that important? If you thought, we went through a narrowing process to pick the 13, but then using that composite measure criteria, we wanted to make sure that we were addressing different domains or different ways the healthcare system can impact impact kindergarten readiness. So one easy way for us to do this, because we had this visual, was if we pick number 1, 5, and 8, do we have different shapes? And if we had different shapes, then we know we were addressing different domains. So it was an easy way to make for really hard conversations. The second thing is the colors. So you see in red numbers. So the numbers correspond to, of those criteria I showed you, on average, the mean across the entire work group, how many of the 13 criteria the work group felt that metric met. So the higher the number, the more the work group felt that metric met more of the criteria within the health aspects of kindergarten readiness. So the metric with the highest rating, according to the criteria, was follow-up for developmental screening. You'll also see that some of the metrics have blue font. The reason the blue font is important is that social emotional health and addressing social emotional health and the early learning system playing a role in addressing social emotional health came up from the very first meeting and played out for every single meeting. And so the work group really told us, you need to have a metric and you need to have a theme around addressing social emotional health, because we think it's one of the places where there's the biggest gaps and the biggest need. So metrics that have blue font are metrics that in some way address social emotional health or factors that impact a child's social emotional health. And so again, when we were plugging and playing shapes and saying well, what if it was these 3, or what if it was these 4, what if it was these 2? We were looking to see, did we at least have some with blue font, because the group wanted us to make sure we had an explicit focus on social emotional health. And then the last thing that I'll note that I think is super duper important is what's in parentheses, and that's the data source. And the reason the data source is important is because there are limitations and strengths to every data source. If anyone tells you that there is a perfect data source, they have not actually looked at their data source. So claims data has a lot of strengths and it has a lot of weaknesses. And electronic health record information has a lot of strengths and it has a lot of weaknesses. And CCO report of their systems and processes has a lot of strengths and a lot of weaknesses. So we wanted to make sure, again, when we were plugging and playing which metrics would best meet the kind of goal, drive and catalyze work towards the goal, health system behavior change and investment that contributes to kindergarten readiness, we wanted to make sure that we had different metrics with different data sources, because then we were playing to the strengths of each data source and the weakness of each data source. And we were helping to galvanize momentum based on data and information that pulls from the different strengths of those data sources. So then we have these, yeah.
Colleen, maybe you're going to do it later. On 5, I'm curious what it means that the follow-up would replace the screening. So if you're going to discuss that later, that's fine. Yes. But if not, I'm just not following.
I will address it later. I figured you guys were going to ask
me
questions
That's great.
That metric, so I added slides on it last night. And then if I don't fully answer, you can bring it back up, Bobby.
Okay, thank you.
TBD is a great data source.
Say it again. I couldn't hear it, David.
I see that TBD is a great data source.
It is. This is when people tell you, this is the metric. And I'm like, is that a metric or is that a concept? Like, and I'm a measurement person. Like, you don't get to count it as a metric unless you, 1, have a data source, 2, you have a numerator, 3, you have a denominator, and 4, you have a way of scoring it. Like, that to me is like, unless it fits those, it's not a metric. It's an idea or a concept. So yes, that's why it's not in the near term, David. That is a 3 or more years process. Super important, but 3 or more years. So then we had to figure out, like, we can't go to metrics and scoring and say, okay, group, we've done a great job. I know your current list is 19. We are going to ask you to add 13. Thank you. Look forward to talking to you. Like, that wouldn't work, right? And the work group wanted us to be successful and in having a successful strategy that could be adopted and move things forward. I will tell you, this is the most painful part of any measurement project. I've had to put metrics into NCQA HEDIS. I've had to put metrics into a national survey in which you get 3 items. It's the worst part because I think our work group would say all of these metrics are important, every single one, and I could fight for each one, and that's true. Each one of them is so important. But we had to think about what would be most likely to have success, could happen in the near term, so in the next 3 years, and would most likely galvanize work towards our big picture goal. And so there's tough decisions to make. And so we did that as a work group, but then we also tried to really make sure we got a lot of stakeholder input and feedback on that process so that, you know, we were hearing from a bunch of different people. So we reached out to the committees themselves that would have to endorse these metrics because whatever we propose isn't a guarantee. The committees that call for the metrics themselves have to approve of them. So that the Metrics and Scoring Committee, the Health and Quality Metrics Committee are 2 committees that would need to endorse the individual metrics and the strategy. And then the CCO Metrics Technical Advisory Group are people that kind of think of the devil in the detail. We had the fortune of engaging with the Early Learning Hubs a couple of times. We reached out and then had a call for primary care providers. And then there was a survey done of families about their insight and input. And we use that information to kind of help inform and guide us. And so we heard a lot of things from stakeholder input. These circles kind of all represent the different things that we heard. I'm gonna skip these slides just because I'm sensitive to time, but you know, I do think that when you kind of again look at the 4-part and you go, well, why did they pick those 4 from the 13? It was 1, our measure criteria, but 2, we really heard from stakeholders what these different circles represent in terms of you know, things like caution against metrics on screening if there's not follow-up available. Metrics like making sure that you don't wait for, as you saw in that diagram, we had a number of metrics that would be in 2 or 3 years, and there was strong input of like, get things going now. Like if you know of something, start moving now. And then kind of being really thoughtful that there's a lot of changes happening right now. So how could our metrics align with what CCO 2.0 priorities are? Thankfully, I think there's really great opportunities. We're in a state that I think called out some really great things specific to 0 to 5. So where we landed is, again, we had to kind of think about kind of metrics overall and kind of thought about how we think of this as one lever, but not the only lever. And so I think our final report, when you read it, tries to give some of the kind of broader important components. But we really wanted to kind of use that big framework in order to then kind of think about, we need a multi-year measurement strategy. We're one, not proposing one metric, and two, we're thinking of a strategy for implementation of those metrics that happens over time. And so, and we're doing that because of all the preamble I just did for you. And we want to make sure that we have a metric that, metrics that are ready to go in the next few years. Because while we love some of those metrics on that far right, we don't want to wait for just those metrics in order to move things forward. So where we landed is on these 4 metrics, and I'm going to go to the next one because you saw that visual. So one, you will see there are different shapes, right, you guys? Like you have some squares, you have a rectangle, you have some blues in there, you have color, so we made sure to address metrics that would include a focus on social emotional health. And then we made sure we included the 2 metrics that had the highest measure criteria score. So the 4-part measurement strategy that, again, we're proposing would be implemented over a series of years is first, the preventive dental visits for children 1 to 5. There are no metrics within the metrics and scoring program that focus on dental health for young children right now. So it is a gap in terms of that service area. And the well-child visit metric for children 3 to 6. Then the second metric that we are proposing is a metric that would fall, in our measurement criteria or conceptual framework, we had that far right blue column. This is a metric that falls into that bucket. So the denominator for the metric is the CCO, and the numerator for the metric is whether that CCO did a series of things that addressed screening, capacity, utilization, policies, and payments that all kind of impact social emotional health. And I'll talk about that in a little bit. And then the goal for that work would then be in the future to take that metric out because you galvanized and force some of the system, policy, practice level efforts that need to happen, and to instead replace it with a child level metric that would be able to indicate whether those systems, policies, and practices are actually impacting children in a positive way in terms of their social emotional health. And then the 4th and last metric is a metric on follow-up to developmental screening. And I'll talk through the replacement when I talk through the metrics. The last thing that we're recommending is that all of these metrics, plus existing metrics that are currently in the incentive metric program, are stratified and reported in order to examine disparities. So to examine the current and these metrics for children and youth with special health care needs, so that you can start to look at gaps. To look at the current and these proposed metrics by race ethnicity, for example. So I'm sensitive to time, so what I'm going to do is you're going to get these slides. The preventive dental visit is a fairly easy metric in the sense that it's looking at claims data and whether children came in for a preventive dental visit from a dental provider. Bright Future's recommendations are that starting at 1, a child should have an annual, actually biannual, preventive dental visit every year. The well-child visit is kind of your classic, did they come in for a preventive care visit overall? It doesn't get at quality, but it gets at access. And you can see kind of the data about the gap in terms of where we have some opportunities. The CCO level attestation metric, again, that's really meant to focus on.
Yeah. Sorry, David's got a question.
Just a quick question on, is the age group there because 0 to 3 was already covered with well-child visit? I was just curious about the 3 to 6 on that.
Sure. So there is, in terms of existing metrics already spec'd out, ready to go, can be applied at a CCO level. So do they fit our minimum criteria? There is a well visit metric in the first 15 months of life. The work group assessed that, and if you go back, it had a same measure criteria score, relatively low actually compared to other ones. The reason the work group ultimately didn't decide to include that in the measurement strategy is because there are other metrics in the current incentive metric program that already focus on that population. And they're like developmental screening, for example, focuses on 0 to 3. The immunization metrics can focus on that population, but there are no metrics that focus on kids 3 to 6. And so the idea was like,
population
there's a huge
spread.
gap.
Okay, that's helpful. Thank you.
And unfortunately, you can't create a metric that's like well child visits for 0 to 6. I've tried, because the recommendations are really different. So it would be a like 5-part metric, because the number of visits that a kid under 1 is supposed to have is not the same as the number of visits that a kid 1 to 2 is supposed to have. And so that just creates somewhat of a messy, like what counts in terms of the well child visit criteria. The attestation metric, again, this is like CCOs would be, it would be a metric at a CCO level. This is a new metric, and it's a very innovative approach to try to drive improvement. And so we have work to do in the next year to really develop this metric and develop in a way that is feasible and is sensitive and that drives the kind of work we know needs to happen. And so for the work group, we kind of agreed that we wanted to have a metric that was at a CCO level. The work group did not like endorse or get specific in terms of how that metric would get applied, because that is a development work that needs to start happening now. We did agree that the components of the CCO level attestation metric from a work group point of view should include these 3 big buckets. 1, examining and expanding screening for and identifying factors that impact social and emotional health. And that is including social determinants of health, given they impact social and emotional health. 2 is assessing the capacity and utilization of behavioral health services for children 0 to 5. I think because of your early learning lens, that is using the very broad definition of behavioral health services. That is not using a specialty infant mental health definition only. And then 3 is addressing the policy and payment barriers for behavioral health services. Again, this is a CCO incentive metric, so thinking specifically about the barriers that have been identified in terms of providing behavioral health services for young children in a dyadic therapy way, which means with their families, because there are no behavioral health services for young kids that are not with their parents, that are kind of within primary care and specialty behavioral health care. And so these were just examples that the work group played out. Again, we would be developing this metric now, and that development work is going to be led by OHA and partners, and that's being fleshed out. But the goal will be to kind of think about how to develop this metric, but with the proposal happening in the fall or early January. So Bobby, to answer your question about follow-up to developmental screening. So 1, this would be a EHR-based metric, meaning based on the electronic health record, what was the follow-up? I would be happy to spend lunch with somebody or time on the side of a soccer field, because that's where I am a lot on the weekends, of why does it need to be an EHR metric? There are reasons, because there's not a claim that's going to validly get at follow-up, and a lot of the follow-up is outside of healthcare. And so as a first step to kind of understand within the healthcare setting, did they do right follow-up, which can include follow-up outside of healthcare setting. One of the most valid ways you can look at it right now, from if you're trying to understand the screening that happened in a healthcare environment, is to look at the EHR. And so we, OPIP, have been doing a lot of work around that and would be developing the metric. We've been able to implement it in a number of sites across 10 counties. And there is going to be different scoring, and that's going to be the development work of, for an incentive metric program, what version would we use? And then I put in the slides kind of all the development work so you guys would know, I know how hard this is going to be. We're deep in it. Bobby, the reason we're proposing that it could potentially be used to replace the developmental screening metric, but we're going to be really thoughtful about that replacement, is the developmental screening metric is rapidly increasing. They set the benchmark quite high this year. It's at 80. What's the rate, Sarah? 80?
I can't. Is it
80.4 for some reason.
80.
It's high.
Benchmarked against it, but it's high. It's at least 80%, and I can't remember the exact.
Again, that's for continuously enrolled children, and there's a lot of kids not getting screened, or that you don't know that they're screened because they have claims data. We could have a whole side conversation about that. But we're never going to get that metric to 100% because there is an appropriate population of children who shouldn't be screened. A kid with significant cerebral palsy, for example, like that would not be family-centered to give that kid a developmental screening tool. So as that metric gets higher, people are going to say, well, that one should come off because we've reached our goal. The purpose of the incentive metric program is to galvanize and move forward transformative activities and to incentivize it. There's a lot of things that OHA tracks at a CCO level and reports at a CCO level that isn't in the incentive metric program. And so some would say once we get to a high enough threshold, there have already been conversations of like, why is developmental screening holding that seat? So as part of our strategy of trying to say like, we're not going to recommend 20 metrics to add, part of our strategy would be to say, we propose that you sub out developmental screening and in place put in follow-up to developmental screening. But some of the development work that I want to do and that Sarah and I are going to brainstorm on is how do you make sure that there's still the incentive for them to keep their developmental screening rates high? Because you don't want a site to say, oh, you know what, if we're accountable for follow-up, let's make sure we just screen less kids so that we don't have to do follow-up on as many children. When you work with practices that are implementing, I think the likelihood of that happening is not super high, but the likelihood of them maybe not addressing the gap of children not screened could happen. And so we're going to think about ways in which you may not even be eligible for that metric unless you have a base level of quality. But this is a new game. Metrics and scoring there haven't been a ton of metrics that have been cycled off. So I think we're going to have to be creative, and I'm really excited about this development work about how do you make sure we own the gains that we have, but how do we also make sure we move forward? You may not have solved that in the data, but this is work that I'm doing all the time, and it is devastating for me. In every practice that I've worked with, the follow-up to developmental screening rates are very dismal. Most practices, their follow-up rate is between 29 and 40%. I've only had one practice that scored at 68%, but I'm not sure I think that's true in terms of some of the rates. So most practices, I just finished in Bend, and one site was 19%, and the other site was 21%. So that's of the kids screened, identified at risk, majority aren't receiving follow-up. So that's what that kind of metric would be.
Is there an assumption that when a metric cycles out of the CCO metrics, it will cycle out for all CCOs at the same time?
That's how it works. So
Okay.
there have been 7 measures that have been retired.
Okay. So you couldn't do something like until you get to the 80% threshold, meaning that's your metric, and then after you get to that threshold, then you move to the referral metric, because that would have different CCOs with different metrics at different times.
Correct. That would not be the framework they've used thus far. Okay. They could consider something like that in the future, but it would be new.
Okay.
So my question is there any way, so a number who do, a percent that do follow up, excuse me, if the number that gets screened continues to go down, it's like, how do you interpret this? And I'm guessing that you've decided there's no way to put the two together, but that's what it seems like we would need to know.
Yeah. There are ways that we could continue to track it, Bobby. Because it's an EHR-based metric, they're going to have to do a sample of EHRs, because we couldn't possibly, ask a CCO for all 96110s. You need to go make sure you have, in terms of the current EHR-based metrics, the CCOs aren't getting child-level data for the EHR-based metrics for the most part, just because of the state of EHR-based metrics and the state of data sharing. So what they're often doing is getting reporting from practices about like what counted or didn't count, and then that would be kind of how they would understand the sample. Now, if that practice can generate an electronic version of an EHR reported metric, then potentially question mark in the future. It's just that the CCO doesn't have everybody on an EHR reported metric. So it's a lot more complicated than I'm making it sound, and we could spend a whole hour on that.
Right.
The problem is the data system, the simple way to think about it is there is not currently a way, it's where the field is going, that you would be able to say, give me at a child level, for all these 9610 claims, give me at a child level what their follow-up was. Because the data sources are different, and the way we're getting the data and the way we're connecting them right now doesn't allow for that child level. But you could look and see, we're still going to keep tracking. I doubt OHA will drop developmental. Actually, I know OHA will not be dropping developmental screening from tracking, because developmental screening is still a CHIP or core measurement set. So state Medicaid agencies will be required, when we propose this to be removed, at that time, state Medicaid agencies will be required to report the metric, and it's also just been selected to be on a Medicaid scorecard. So there's going to maintain a lot of energy around screening that thankfully doesn't necessarily need to be through an incentive metric program.
Well, and there's also the opportunity there's also the opportunity too, in terms of tracking the claims-based developmental screening, in terms of how you benchmark a new EHR-based measure. So the committee will likely want to look at, well, how they're doing on the follow-up piece, but they're certainly going to want to track, and they're going to have significant concerns if they find that the screening piece is dropping, because there would be a perverse incentive, right? If you're only looking at kids that have been screened and then need follow-up, if that's what you're focusing on, to not screen. So there'll be lots of conversations there.
So I guess my basic question is, when someone is looking from the outside about movement on the metric, is there any way to put the two pieces of information together, even if one is an incentive metric and the other is not the incentive?
Yeah.
It's being measured, but it's not an incentive.
I think there's a way at a proxy level that you could put the two together of, like, when we look at this CCO, this is what's been happening with their developmental screening. And that same CCO, if we look at it based on the EHR, we would be able to look at those two stories combined. But at a child level, will we be able to look at those two stories now? But at a CCO level, in terms of the population composite level information, yes. It's just the ways you potentially get at the denominator are a little different.
Okay. Is this going into the areas that you hope on the longer term work will be continued? Or is
this idea that
or is this just the best we can do?
So Bobby, I've been working on this in 12 years. I think this is the best we can do right now. And it's pretty novel. Nobody else has done. What we're doing is pushing boundaries pretty significantly. Okay.
I think the biggest question that's in my mind is, and not understanding the systems makes this really hard, but the CCO level versus the child level, and that was where my head was going. Is this just too big to think about this ever becoming child level?
What's ever to you? What's the definition of ever? I don't think it's too big for that it's not going to happen.
10 years.
I'm hoping I'll still be working. I'm hoping it's not that one of those things I pass on to my kids and say, good luck with the follow to developmental screening metric. It's more the state. I think our state is doing a lot of great work around trying to support EHR-based metrics, because we know that claims data is limited, and we know that we need data that's from the medical chart. How you get that in a searchable, queryable way that would allow you to connect at a child level, that's a place that a lot of us are focusing on. I think it's very humbling, but I think you have a lot of trains in the state that are pushing towards that. Sarah, would you like my big picture statement on that, Sarah? Do you agree? Is there anything you would say differently?
I agree with the big picture. I also agree with the definition of what do you mean by take it sometime in the future.
Yeah. Just at a like basic high level, I just want to make sure I have a sort of understanding. As part of the challenge with electronic health records, it's a lot of information. So actually, how you score it isn't always no.
No, I wish it was that, David. The fundamental way to look at it is that electronic health records were not developed for measurement. They were developed to track and claims process, right? So the problem that we have right now and there is no standardized all electronic medical records shall have blah. CMS actually tried to do that in CHIPRA. They came up with like the model EHR and said anybody serving children should have these components. And then all the for-profit EHR companies were like, yeah. And so then they end up like charging people, and so different people build things. And so EHRs are kind of now playing a number of different roles. They're one, how you document what you did, they're processing claims, and then they're now, they're being used for measurement. For most, I just had my first practice that was able to run this fully on reportable information in the EHR, and I literally cried when it was pulled off because I was like, it's possible. The problem is that if I think of it as like, how do I make this in simple terms? If I type into Word a bunch of words, you can't track what I've been typing into Word. But if I put into Excel in individual cells, I screened the kid, I referred the kid, I gave them parent education materials. So if I wrote a paragraph in Word, you wouldn't be able to track my paragraph over time, right? Because it's a big glob of words. In an EHR land, in open field text boxes, you can't measure that. That's not in what's called a searchable field.
And that's actually what I sort of meant, like someone actually has to look at it and interpret what it says.
But to add on to this,
what I'm saying is people that use EHRs, there is a way to build EHRs, and there is a way to use your EHR appropriately that would allow you to track it. So, for example, Mosaic is the site that I just worked with. They are on Ocean Epic, which almost all the FQHCs in this state are in. I've worked with a number of state FQHCs who could not run the follow-up metric using Ocean Epic. Mosaic could, because Mosaic uses Ocean Epic. One, Ocean Epic has developed great templates, but two, they use it right in order to generate the kinds of searchable fields. So, for example, I have worked with a number of FQHCs who don't generate a referral to early intervention in their EHR. They only put it in the Word text. So there's no way for me to know, did they refer to look at the kids who are at risk and then say, did they refer to EI? Mosaic uses a function that's like referrals, and they use it for anything that they do, not just medical referrals. So that was a way that now they have searchable data that they're not just dumping into a chart note, but they're using their functionality better. Now, would Mosaic be willing to share that child level data with their CCO so that their CCO could connect, I have this claim and then these child level data? No. So that's part of the issue, Bobby, is like how they would actually pull, and would they be willing to give clinical information, like one, do they have the capacity and skill set to be able to do that? And two, would they be able to do that, to give that to that CCO to line up with their claims data? No. And if only one of the sites can do that, if you have, let's just play out, you're in a community, you have 10 sites. If only one can do that, then in terms of a population level, that's the disconnect between what you can look at a CCO level versus what could you look at that's based on clinical data, and the differences in practice capability to be able to give that information.
Sorry I asked.
Thanks, this is very helpful. I just noticed the time, and Colleen, are we impinging on the rest of your day?
Just a little bit, but that's all good. So you guys got the recommendation.
Okay, great.
You're seeing that our proposal is to adopt 2 metrics now for the incentive metric program for 2020, and that's the well-visit preventive dental, to adopt the CCO attestation level metric for 2021 or 2022, and then for the developmental screening metric to replace the follow-up developmental screening metric. And so what's really cool is that the metrics and scoring program endorsed the concept of this strategy and the idea of this strategy, and health plan quality metrics endorsed the strategy, and they would have to first approve, health plan quality metrics would have to first approve of number 2 and number 3 because those aren't on their current list. But so we've gotten great conceptual support and great support for the kind of like idea of a multi-year strategy that happens over time. And so now the work is to develop the metrics and get the final approvals at the metric level and get those adopted into the set in terms of approving the metrics at a metric level. Sarah, you want to take from here?
Yeah, so I do want to give a big caveat is this first bullet up here about the 2020 set, which Colleen was talking about that, the first part of the strategy, which is the preventive dental visits and then the well-child visits for 3 to 6-year-olds. The Metrics and Scoring Committee endorsed the entire package. And to Colleen's point, this strategy has to be implemented as a package. That is what the work group is very much saying. It will not work if you just implement parts of it. That said, the Metrics and Scoring Committee did endorse, they were very fond of and endorsed the package, but they don't make their final decisions about the 2020 set and those 2 measures until the summer. And there are a lot of measures that folks are putting forward. So I want to just put, while they endorsed the package and the work, and we at OHA are working with Children's Institute and other partners in moving all of this forward, the final decisions are not going to be made until this summer. And certainly just for folks to know, those are public meetings. If folks have an interest, they can provide public comment. They are very interested in public comment. So that's a caveat there. But that said, we have already started work on the developmental work on that plan level attestation measure on social emotional health. And then Colleen is working on the follow-up to developmental screening metric to move forward, because again, it's the package that is so important. Can you go to the next slide for me?
She's got, oh, did she hop out?
Colleen, are you? Oh.
And I moved it to the next one.
Okay, thank you. And then we have a final report, which a work draft of it was put forward to the Metrics and Scoring Committee, and Children's Institute is working to finalize it for further publication. But we wanted to kind of call out some of the things in that report that the work group had endorsed with relation to the early learning system specifically, and these are quotes directly from the report. So the first is, where appropriate, align the measurement efforts, and measuring success was called out, as well as the Hub Indicator Work Group, with our conceptual framework. And Colleen and I have been here and talking with you all about that, and we've been working towards that together. Also utilizing the child and family domains in the framework and looking at those columns, to align with the services provided by the early learning sector, so that we're kind of marching to the same hymn sheet. I'm going to merge metaphors there. And then also look at, so there was the slide where it had all of those, we had those 13 measures that we had been looking at, and some subset of those are ready to use. They have standard specifications based upon the limitations of the incentive measure program and the strategy that we had to put forward. We couldn't use all of them, even the ones that were, ready to go have specifications, but, consider using those, but for the early learning division or the council for dashboard monitoring, because we have, you could see within the framework that we have, these are all really important in terms of what the health sector can do to get kids ready for kindergarten. And though we couldn't necessarily get them into the incentive program, let's leverage other opportunities. And then I think the last slide is just our contact info. Oh, no, even more. It's fine. Go to the next one, Colleen. I don't need to say the stuff. But so you have access to Colleen and I if you have any questions. But I do want to call out, this was such a wonderful collaborative experience with Children's Institute and OPIT and our and we kind of see this as the commencement of the work. That was the initial work. It gave us, what our vision is and what our stepping stones are to get to that vision. And the Health Authority is really committed to continuing forward with it.
So this is Bobby. In terms of direct implications for this work, I mean, it's wonderful. Thank you so much for what you did and for sharing it with us. But to do the link, what I'm hearing is it would be premature for us to include the first 2 metrics until something, the action is taken in summer.
So
but
I think
okay, great. No, we could use them.
Yeah, the first two metrics are reportable. You saw the data; they're able to be reported. It's just whether they're incentivized, but they're metrics that are based on claims data.
First, CCO tracking metrics,
Okay.
even though they're not incentive metrics. Those first two.
Yes, great. I think
we are not. Neither of those are currently tracked. But there are specifications, and
they're trackable.
They are trackable, as well as some of the other metrics.
Okay.
So then, okay.
Partially, Sarah's point is there are also ones in 13 that are also trackable.
That was my next question. Are you also advising us that we should look at the 13 to see how? Okay.
Yes.
Thank you.
And then
I will just make a
plug that the health. Yes, and I will just make a plug that I think this is a different presentation that we did, but one, there's the metrics overall. Two is you have the health complexity data for 0 to 5. And so how does that, when I look at some of the measurement domains, I think the health complexity data itself is helpful, but also what if you looked at well-child visit rates for children with high social complexity? To me, that is a very strong alignment with some of the early learning priorities and an opportunity given where our state is.
Okay. And that's in the 13, am I correct?
No, unfortunately.
It's not. Okay. No, it's not. Okay.
The health complexity is a population-based metric, so think of it as like a denominator. Well, one, from a early learning system point of view, I think it's a very helpful population tracking tool for publicly insured children. What's their level of health complexity? And we intentionally reported it at 0 to 5 because I'm a pain in the ass about 0 to 5 always, right? And then so is OHA. They care a lot about 0 to 5. So one is in itself an indicator of health that will be tracked and is available in our state. Our state is the only one. But two, it also could be used as a denominator to look at gaps and disparities for things that you identify for your numerator. So dental visits, you could look and see children with high health complexity or children with medical complexity. Are they more likely to have lower dental visit rates? My sense is probably. We shall see. But that could be a great opportunity.
So what I'm hearing is this committee has, as next steps, that the two that are being being proposed for immediate as incentives, we could incorporate right now. But then we should also have conversation about how to use, these are measures that are available, how to use the health complexity either way, either measuring it or using it as a denominator. And then the third thing is we should explore the 13 to see if any of those should be brought in. Did I hear the measuring success next steps?
Yeah, the one thing I think Sarah and I should do is, Sarah, there were metrics that didn't make it to the 13 that we assessed that were ready. We should just look and see if any of them we think conceptually align well with this framework. I don't know what off the top of my head, it doesn't, I feel like that's fine. I just want to make sure we pruned. I just want to make sure that in our pruning for our specific goal and our specific, that we're not sharing that work that we did. And that'll be super easy. We can look at a table and be able to tell you that.
Okay. So I'm going to add a fourth that says the two of you will determine if there's others we should look at because of their alignment.
Because they could be ready to go. I mean, the lens I'll be using is, are they metrics that are spec'd out and are based on data sources that exist that could be ready to go?
Okay. So they're ready to go and they align conceptually.
Yes.
Okay. So we've got 4. We've got 4 things for this committee to do. Okay.
Yep.
All right. Tom and David, do you see, I'm trying to get it, this is such great information, but apply it to our work. Are there other things that you see we should get on our to-do list?
I just think considering the measure criteria and denominators, I know that's been hard for me sometimes in helping think through which metrics fall in or not, is that we have, to me, I think you guys did a great job of coming up with a conceptual framework. Like we have a framework that we're thinking of. I'm not sure we've identified what criteria would make this a good metric to put in.
So you're saying that before we move forward, we should stop and develop criteria for what we're looking for?
For assessing, does this metric, I guess I need to understand, you know, not having been on the calls lately, which is my fault, how much is the goal to kind of fill this in with whatever is available? And or will there be a goal that over time we are going to want to have like a parsimonious set of metrics that we're using to track progress and we're using to track the state? And if that second goal is there, then it is often useful to have criteria that help you determine, does this metric meet that criteria? It also helps you just assess, just because a metric exists, is that a good metric for assessing the goals of the early learning system? Like, does it fit the components?
Okay. Go beyond, is it possible and feasible?
Exactly.
Okay. Well, that sounds like step 1. Tom and David, I mean, doesn't that sound like step 1?
Yeah, I mean, we did do this a while back, very quick. We came up with some principles for our long-term measures and our intermediate measures.
So, you know, I think we did develop some principles for the intermediate measures. I think one of the conversations that we started but didn't finish, but I think we wanted to sort of wait, was the sort of question of the scale of the dashboard, because I think there was a sort of a tension between, in general, the power of parsimony, but also the desire to be both comprehensive across domains, but also across the work of various partners.
Right.
I think, you know, my sense is that.
So maybe it's just reviewing what we've already done in light of Colleen's recommendations. Is that is that closer?
Well, I think where we were was we had the sort of initial library that we had been sort of developed. And where we left off last meeting is we got through just a couple of them, sort of reviewing them of what additional questions that we needed to work through. And I think Tom has been doing some of the work in between this last meeting and this meeting, both on additional information on the ones that we had already looked at. And then I think there was also just wanting to continue to review where we were in that process. So I think that's what Tom was going to lead us through next. Is that right, in terms of the agenda?
Sure. That sounds good.
David, just stop a minute, though. Are we saying that, I mean, Tom, you've done impressive work, and I'm anxious for you to share it with the group. How does that relate to this recommendation that we are, that we're sure our criteria are right? I'm not making the connection between those two activities. Is it that Tom's already applied the criteria and we don't need to look at them again?
I guess the way I think of it is the sort of both the assessment of the measures by criteria and the assessment of the criteria is a little bit of an iterative process, I think, with what we're trying to do. So it felt like, you know, I think that may be worth coming back to, but I'm not sure it's worth coming back. This is exactly the right moment to do that, I guess, was the question.
Okay. Oh, okay. So this goes on our more long-term work plan. Is that what to keep doing what we're doing, which Tom will lead us through, and then and then knowing that we've got this on our list, one more review of the criteria we're using in determining if they're if we've got the criteria as clearly defined as we want them to be. Is David, in my hearing, is that what you're saying?
David stepped out, but I think that's generally what he's saying, is that we have some more work to do just to fill in some holes with ideas. And then maybe as we get closer, in the polishing phase, we need to go back to, reviewing each of the suggested measures against our criteria and maybe do another look at it.
And probably do one more look at our criteria in light of the suggestions we just heard, and then apply them, is what I'm hearing. 2 steps.
Right. Yep, that sounds good.
So review and apply when we're through this next step.
Yeah.
Okay. Great. So Tom's going to take it. And Tom, just so you know, I do have parent ed responses. That can wait till next meeting, but I do have them.
Okay. No, we'll get to those. I think the first thing I wanted to start off with, it was like one of the big questions we had at the last meeting as we were going through was getting some more information on 2 of the data sources, 2 of the national surveys, the PRAMS and PRAMS 2 surveys versus the National Survey of Children's Health. For example, like when the long-term measures for goal 1 is frequency of reading to children, and that information is available both from the PRAMS 2 and the National Survey of Children's Health. So I put together a quick kind of overview. Anybody who knows more about the PRAMS can chime in. Just for review, the PRAMS 2, and the NCH are all, the PRAMS and SCH are all national surveys. The PRAMS 2 is an Oregon follow-up at age 2 for the children. And the National Survey of Children's Health lumps all kids 0 to 5 together for some of the indicators. We can just go through. The average sample size, some of this is from the media materials and other data. I do now have a sample of PRAMS and PRAMS 2 data to look at, so we've been able to make some progress there.
This is Oregon only sample.
Yeah. And these are the Oregon only sample sizes from both of the surveys. As far as I know, they're fairly similar. I talked to Suzanne Zane yesterday and confirmed the general turnaround time for the PRAMS 2 is about 6 months, which would be the very earliest we could get our hands on data, which is pretty good. The turnaround time at the national survey is about 1.5 years, depending on the variable. Sometimes they'll take 2 years to measure a variable, sometimes just 1, because of sample size and everything. Subgroup reporting is not currently available for either, because the sample sizes aren't big enough.
For any subgroups, none?
As far as I know. I mean, I believe it's sampled representatively, but not high enough.
Right, and it's only available at the state level, it's not like county level?
Correct.
So, okay.
Correct.
Sorry.
And then whether it's comparable to other states or the country as a whole, maybe we could do it for the PRAMS 2. It's easy to do for the NSCH online. Now at the bottom I have some of the considerations. Both these 2 topics, as well as the idea of considering a multi-agency population survey, is now rumbling around the different agencies, thanks to the last meeting we had, for better or for worse. Because the issue came up with the National Survey of Children's Health, which is offering states the ability to oversample. So you can get better state level data as well as look at those subdivisions and subgroupings. That's expensive. And it's probably around what? Well, it depends how many subgroups you want to analyze by and all the various things, but it could, you could be looking at several $100,000 for an oversample probably every year.
Would you also expand the questions asked or just expand sample size?
You would expand the questions asked as well. And there's currently a work group debating that is just beginning to discuss that. So so in this context of this discussion is where people started throwing out the idea, well, maybe we should just all get together and do one big population survey again, because it might be the same amount of money as doing a more limited oversample of NSCH. So all the higher ups, we got to get moving on. So the idea, right?
Interesting.
And the other thing that I've heard about the PRAMS 2, although this is just unofficial right now, is that it may be moving to the PRAMS 3. So they'll be collecting it at 3 years old instead of 2 years old.
Do you have a timeline when that might be implemented?
I think we're looking at, a couple years, because that's all I've heard of so far.
And I'm sorry, Tom. So I think the PRAMS is the national survey that's run out of the CDC. PRAMS 2 is the Oregon just follows up those same kids who were in the original PRAMS that were sampled, so it's a follow-up of the same sample.
Yeah. Okay. It is longitudinal.
That's kind of cool.
Where you lose a lot more at age 2.
Yeah, of course.
But they've been able to keep it up. So with that said, there are 2 other handouts. One is I found a map of all the items from the National Survey of Children's Health, or at least 2 parts of the National Survey of Children's Health. Not that we want to go through and consider each one, of course, but you can see some of them here are relevant. There's the family reach to children, or things and tell stories to children, exclusive breastfeeding, low birth weight, and some others. So there's that data source, and then a second handout, I've listed PRAMS 2 measures, the actual items from the PRAMS 2 that we've identified in the PRAMS 2 could possibly help us out. So there's 1, 2, 3, 4, 5, 7 measures from the PRAMS 2 that could potentially be used for our dashboard. If we are interested in using PRAMS 2 data. And some of these will require some follow-up work about where, how we're going to measure it or report it. I think.
Tom, one of our criteria is that somebody else is doing the analysis and reporting it. So it's not that ELD would pick up responsibility for measuring and reporting PRAMS 2 or the other health survey, but that probably OHA, I assume is the candidate, is already doing that, and it could be, and they'd be willing to share it in the dashboard. How does that fit with what you're saying?
Yeah, I believe that's the case. I think there may be situations where decisions have been made to group certain categories or groups together and report it at a certain level. We may want to reconsider that. I don't know all the specifics. I'm just thinking, for example, that maternal depression is 3 parts, A, B, and C. And I don't know if they do a composite sum, or how they, on a scale of 1 to 5, if they total if it's the total points, or if there's some standard definition, or if we want to make up our own definition for what constitutes maternal depression.
Yeah, I mean, 2 of the items, I think, are the PHQ-2 screener items, but I don't know what the 3rd item is. Is that right, Sarah? Do you know?
No, actually, you know what? I can pull it up.
For all the different combinations of depression items, this is a strange 3.
I think the PHQ-2 has a 2-item screener that I know they use in McVie, and we use in Healthy Start. So it seems like it would align with this one, but I'm not sure where the third came from. Or whether, I can't remember.
PHQ?
The
PHQ, yeah.
patient health questionnaire.
The one we take every time we're going to
You should do.
And for example, maternal stress and maternal social support, those are ones where I'm not sure if they just report it by individual item, and we might want to do a composite. Either way, the possibilities are they produce the report with their some calculations, some just by the percentage endorsed, and then also I'm going to be getting the raw data for any additional follow-up we want to do.
Right. I mean, usually maternal stress, these are stress. Those are usually reported as sums. I don't know this particular.
I'm sorry, the reported is what?
A sum. So they would add up the yeses and the no's and report like the total score as opposed to the item scores.
So Tom, when you say that you're going to be seeing what can be done with the data, is that in the hope that OHA would start doing that analysis and reporting it, or that ELD would add to its work an analysis of the PRAM on a regular basis?
No, I think for the ones they report that are straightforward, we'll just use their official reporting, and then I think probably develop our relationship a little better, and then ask them to do any future calculations, which I think they'd be happy to do because they're anxious to get this into the stakeholders' hands for use.
Okay.
They sound like a good group.
Great. Okay. Thank you.
So, without making any decisions on that, I just want to introduce those 2 sources so we can.
Okay, and Beth, this is really helpful that you're familiar with these measures in multiple instruments, or, so as we move forward, it'll be really helpful to have the kind of input that you're giving.
I'll do my best, Bobby.
Thanks. That's all we can do.
The maternal depression, it's not exactly the PHQ-2. It's really close.
Right, that's kind of what I thought, which is weird. It's not the CSD, no, because it's longer. I think the short version is 7 items. CSD.
So does anybody have any comments on the strengths or weaknesses of the 2 surveys they want to add?
Both seem like potential rich sources of data.
I mean, my concern is the turnaround time for one.
Right, that's the NSCH is a lot slower.
It's not really in our control where the PRAMs 2.
Right. True.
In Oregon.
Yeah, and it'd be even better if they could break it down by some key subgroups and or by count at the county level. I don't know how much of a sample they'd have to have this at the county level.
Not on that size sample, they couldn't, though.
No,
I can't imagine. Yeah. So Tom, it feels like that question of which data source is easier to answer if we've identified which indicators, rather than just a generic, it's PRAMs or it's health, it's, like, I'll do that. If we think maternal depression, which we have really good reason to rank that very highly, if we think that's really important, then it's which of these 2 measures is stronger. Yeah. That'd be easier for me to answer than a generic.
Oh, that's a good point, Bobby. Like, what's the measure that they use for NCHS versus the PRAMS measure? Is that what you're saying?
On the things that we care about, like maternal depression.
Right.
And would that be the?
Right. I mean, the benefit too of doing something like the NCHS is that you'd have national comparators, right? So you could compare
Right.
Oregon to other states, if that's important. But yeah, it'd be nice to see the measures. If we could, I pick out the ones we think are most relevant, and then actually look at how they're measuring it compared to
Right.
trans.
Yeah, that feels right.
So basically, do the equivalent of the worksheet I have for the PRAMS too, just with each of the measures?
Just do it at the table.
Okay.
Yeah, that's great.
Okay. All right. So we'll get those ready for next time. Let's see. So we're still hoping that Megan Bolton from Housing will join us. If she does, maybe we can switch up the agenda to hear some ideas about housing measures. She had said she would be here yesterday.
And how about Kendra? When is Kendra thinking she can join us?
So Kendra emailed me and said that she had a conflict today, but she's trying to rework her schedule, so she'll be with us next time.
Who's Kendra?
Thank you.
And this is Megan. I am here.
Oh, new member.
Megan.
Hey, Megan. Okay.
Hi. Sorry, I'm not in the room, but I am on the phone.
Okay. Did you want to talk about housing measures now? I don't know your schedule, or did you just want to wait till we get to the housing section and hear more about what we're doing as we go through it?
Yeah, that's fine with me. I can just kind of listen and then chime in when I have thoughts.
Okay. And when we'll make sure we get to that section today.
Okay.
Do you want to go to the grid now?
Yeah, let's go to the grid. If you can go up to the top. Okay, and again, the ones in red, we still have some, well, there's probably a little bit of follow-up on all of them, but the ones in red, we have some decisions to make. I'll do the NSCH comparison, so for frequency of reading to children. Goal 1, long-term measure. On objective 1 of goal 1, families are supported and engaged their child's first teacher. I sent out a request for suggestions to the home visiting folks about possible task force measures, and they wrote back and have suggested 3, which we've all thought about already. One is maternal depression screening and referral. And so one thing to keep in the back of our mind is if we want essentially 2 maternal depression measures. One is the long-term overall population, with some intermediary measures being what the programs are doing and whether they're driving their numbers up. And so, and we've heard this from OHA, like about maternal depression screening and follow-up versus just the depression rate. That's,
Wait, but that's engaged as child's first teachers indicator? That doesn't seem quite
Well,
right in
yeah.
terms of our framework.
I guess, yeah, I just skipped to
It would be somewhere else.
what home visiting said.
Oh, okay.
Yeah, and yeah, it wasn't all related to objective 1.
Okay.
What they did suggest for objective 1 is what we talked about, reading to kids. And then again, you know, do we want the long-term population-based, if we can get it, as well as program-based for an intermediary, or is it too redundant? And then well child visits. So they've all.
Wow.
So it's like linked.
Before.
I get, you know what, I thought that what we were looking at intermediate measures that were program level when we didn't have a larger population. But for maternal child health and for well child visits, we do have longer ones. So I think it would confuse people to see duplicates and have to figure out, well, here we're just doing it for this subpopulation that's in home visiting, and it's not even on all home visiting programs. It's just an HFO, right?
All the
Or is
McVie
it
funded
HFO,
programs.
yeah.
I'm sorry, somebody said, I want to what?
So all the McVie funded programs have to screen for depression, so that includes nurse family partnerships, early Head Start, and some of the HFO sites. But all of the HFO sites do it.
Okay, so it is all home visiting.
I don't know about Baby's First and Cocoon.
Okay.
What do I do about it?
I think the bigger question is, did I understand our criteria correctly? That we go to the program level when a population level is not available? Or did I misremember our criteria?
That sounds about right. I guess it's whether we want to rethink that criterion.
Well, the other thing, I guess, being nitpicky, if we think about like what programming for the well child visits, I mean, we're talking Medicaid. It's still a program, right?
Yeah.
It's a lot of our kids, but it's still a program.
Yeah, I guess I mean, the way you were talking about it a minute ago, Tom, and Bobby, you're right. I think that is how we've talked about it in the past, is do we want the intermediary measures to have those like more outputty kinds of outcomes, or even like a subpopulation, which to me makes kind of sense. Like those are the screening things. Like you're not going to shift levels of maternal depression unless you're actually screening and identifying the moms first. So it's more of a logical step. Whereas a subpopulation of here's what parent reading looks like for home visiting programs isn't, I mean, it does relate to the population level, but it's a different conceptual intermediary concept, which didn't answer our question, but it helped me think through what is the question.
Well, I think we're on the families are supported and engaged. Right. Tom, is that right? We're on objective 1, and we thought maybe home visiting would give us a measure of the percentage that are screened, eligible, and then retained for some, 3 months, 9 months, whatever. And are you now saying, because they sent these other measures, are you moving into other objectives? And I'm not following. So can you help? Can you get us?
I probably just should have mentioned there the one measure they recommended for objective 1, which was the reading to kids.
Okay.
We already have that.
Yeah, we already have that.
Yeah.
And so they
as
don't
an outcome.
They don't offer any other measures specifically for that objective.
Right. And the one we have in there is like a program retention. So are they keeping them engaged in the program? Yeah,
or do they graduate or whatever?
They don't graduate.
Call them.
But did they say they don't have that one?
They do.
No, they do. They just didn't recommend it as their best measure.
I see. But we could go back and ask them for it.
Yeah. The question was just put to them, what do you consider to be important measures of success?
Well,
in home.
So they didn't have context.
No context for this, right?
Although I did say specifically with relation to.
Yeah. I mean,
objective 1.
So the other thing. Oh, Beth, maybe you know this. So are all of or some of the home visiting programs using the same parenting ladder that OPEC uses?
I know that HFO uses a subset of the items on the parenting skill ladder that OPEC uses. I don't think it's the full one. I think we've shortened it over the years because it looked like it held together as a short version. But there are a subset of items that are the same.
Because that is one of the OPEC people have never merged the parenting ladder data from HFO and OPEC. So that was one of our questions for them.
Yeah, we could crosswalk it and then see how many items line up and potentially merge it. Yeah.
Is it something HFO reports?
We reported on our on our outcome status report.
Okay. Because that would
hesitated I hesitated on merging when I realized, could you merge it unduplicated? I mean, we can unduplicate HFO, but I don't know if OPEC can unduplicate. Can they?
I don't know.
Yeah.
Anyway, I don't know.
But that's a niggling detail. But we could crosswalk it and come up with items reflecting the parenting skills ladder from both the OPEC and the HFO program, for sure. That we could do. So this could be OPEC, HFO.
Did you have other feedback from Shauna?
Yeah, we have a lot. Okay. They don't use the term engagement per se, but they do ask more than I thought. They collect the number of parents who complete 70% or more of a series. So the term, we could change our term engagement to completion, and I don't think change meaning. And the latter has a self-reported attendance question asking parents to specify if they attended all, most, half, or whatever of the series. So OPEC could, on that measure of engagement completion, we'd have to work with them on which one, but yes, they could give it to us. They use 70% or more as completing the class, and they then for multi-week series, anyway, they get retention. They create a retention measure, and they are open to working with us on that. And then we've already discussed the possibility of doing they don't know what's in that subset that is used in both HFO and OPEC. So I think if we want to pursue this, we need to get, and the OPEC team, Shauna and Michaela, are happy to work with us. And we'd have to get a team that was HFO or Beth, you guys, I don't know, somebody, and look at, could we do these over the combined programs?
I can email Shauna and ask her for a copy of their tool, and then I could at least do the crosswalk.
Perfect.
With one that we use for HFO.
That will take us to the next step.
Yep.
Okay. Great. Okay. So I think that's probably the next step, Tom. But the good news is, yes, we can get this.
Good.
And they do measure what we were looking for. So there's two. I didn't get feedback on exactly what we get on pre-post, but measures of, I assume what we're referring to there is the parents' perception of how much they changed.
That's correct.
So, so I think let's wait and see what Beth finds out about the crosswalk.
Okay.
They're using, it was revised, it was updated in 2014. And so that's the version they're using right now. The 2014 version of the parenting ladder.
Okay.
All right, will do.
If we could move down to objective 3, we needed to make a decision about the second measure. Do we want to look at the percentage of the workforce with the BA, with the master's, or with X number of training hours? Is there any reason to choose one over the other?
There's a lot of policy interest in BA for teachers. So that, and it's BA or higher, so I don't think it makes sense to do MA by itself. It's BA or higher. Training hours has meaning, it's harder for the reader to know what's good. And it varies, and the number of hours required varies with the position. And so, but we could do it just of teachers, for instance, but there's no, somehow you have to tell the reader what's good, you know, whereas with the BA, it's more intuitive.
And there's a lot
that a BA.
You're right. There's a lot
desirable.
of policy driving towards the BA as well as research, even though it's still debated.
Yeah, and I would.
Yeah, still debated. Right.
I would like to make sure we just keep the training hours in. I know there's a question of quality, but especially when we're looking about some of the providers, that BAs, I hear you, that's what we're striving for. But I think it would also not necessarily capture a lot of the early childhood field.
It's so complicated, as Bobby was saying, because the number of required hours varies depending on you're an IA or whether you're a director or whether you're a.
What about like steps? Is that the same thing?
Whether you're a home-based.
Because you have to progress up your steps and then you eventually get to a BA?
No.
Well, the other thing you could do is you could measure steps, but then you have the same problem, and that addresses your concern, Bill, because a step experience and training is all you need to move up on a step. You don't have to get work toward a degree. So, but then what the downside is, like with training hours, people don't really know how to evaluate what's good on a step level. You have to give them, we could give them some clues.
Well, no, aren't there some meaningful cutoffs that we use? Like you have to be a step, I don't know, 7 or higher for something. Or...
Yes, we have, in Spark, we have, yes, we have things
Bobby?
that I think, yeah. Yes?
Sorry, this is Shannon. I'm going to have to hop off here, but I just wanted to say that I wonder, depending upon timeline, whether you and Beth and I might want to put our heads together around some of those more nuanced analysis we did with the validation study and just look at whether there's some recommendations in terms of, because it's not just training hours, but like you said, it's like which training hours in child development, or some of those pieces might be helpful. We've also, with the structural indicators, you and Michaela have looked at a degree in a related field differently than just a degree. So we have some, yeah, I think we could do try to provide a little guidance and some options.
I think that would be wonderful.
Yeah.
Okay. So we just schedule a call sometime in the next few weeks.
I think that sounds good.
Yeah.
Anybody besides, so Beth, Shannon, and Bobby, will come back with some recommendations? Is that what I'm hearing?
That'd be great. Thank you.
I need to have that conversation anyways for another reason. So. Yeah.
Okay, I have to leave. Bye, everyone. Thank you.
Thank you.
And this is Beth. I have to leave also. Sorry.
Yeah, we knew when we went to 4 that that was going to challenge people. Okay.
Well,
Thank you, Beth.
Maybe we could skip ahead and hear from Megan We haven't had a lot of discussion of housing measures with housing folks.
Perfect.
Would that be okay? Megan, is there any?
Sorry. Yep, here. Let me unmute myself.
Did you have thoughts on some housing measures?
I do. So, well, first, I just want to make sure I sort of have a little bit of and I know we talked once before, but I kind of would love to hear from folks on what their initial thinking with this would be, like housing. It says housing security. So, does that mean just having a home, having sort of an affordable home where you're not spending too much of your income on rent? Did you have any initial thoughts on what that would mean? And then I can kind of give some feedback.
My question for you, Megan, was, do you have benchmarks or definitions of what operationalization of what security means?
Okay, good. We do. Yeah. So, generally speaking, we're often talking about the two things I just mentioned. So basically, does somebody, have a home? And in that way, when we talk about kind of homelessness, it can mean either an actual, do they have a roof over their head? But furthermore, is that stable, right? Are they living with friends and family? Do they have their own home? And then furthermore, is that home affordable to them? Are they not spending a significant portion of their income on those housing costs? So those are sort of the basic measures that we're usually looking at. And there are a few ways to look at those. So you have kind of here, I think, point in time, for all individuals or students. So the point in time count does give some okay data on a point in time of if people are homeless or not. The tricky thing with the point in time is that's really focused on HUD's definition. So that's really people who are living in emergency shelters or transitional housing or in a place not meant for habitation, so on the street or in a car. And it's just a point in time in January. So there are some limitations to using that data. The counts are certainly done better in some places than in others across the state. And it's not really capturing those people who may be living kind of right on the edge and being sort of living in doubled up situations with friends or family and really, really homeless as well. So what I sort of might think of recommending, there's actually data that the Department of Education puts out on homeless students. And that captures students in a school year, K through 12, and they have some preschool numbers too, actually, who are any of those categories. So unsheltered, sheltered, actually they separate it into motel, hotels, and then also in those kind of living in doubled up situations with friends and family. So I like that data source because it's a little bit more complete than the point in time, and it's focused on children or students in the school system. So that's one potential data source besides the point in time. And then the other one, in terms of looking at housing, kind of further looking into if a household is stable, kind of stably housed, is looking at that what's called severe rent burden, or housing burden. So if people are paying more than half of their income on housing costs, they're considered severely rent burdened, and that's especially for lower income people. That's a real kind of indicator of a risk, being at risk of homelessness. And so that actually just comes, you can get that data from the American Community Survey in terms of the kind of the percent or number of people in that situation. And we often look at that, again, especially kind of looking at it by income level and looking at kind of the people who might be at risk of homelessness. And you can actually look at that sort of by, you could look at it for families with children, for instance. You could kind of look at those households. So those are my initial thoughts on some.
Can you break that? Does ACS allow you to break that out by race, ethnicity? That measurement?
So we have recently begun doing that. We have to use the microdata for that, and then it makes it a little tougher to do the county breakouts. But we're actually working on that, just because we are also interested in those breakouts. So I'm gonna say yes, although it's a little trickier. And I don't know actually if you need it at the county level, or it sounds like that's.
I don't know. We're not doing this at the county level, Tom.
Okay.
Right? These are state, and especially these are long-term.
Okay. Well, then absolutely you can do that by race and ethnicity at the state level using the microdata, and we have that.
When we did the family impact seminar, the outcomes, the impact on outcomes for children of heavy rent burden, they were as high as, if I remember correctly, they were as high as maternal mental health. And so that moves that one up as a meaningful. We could look in that paper to get the sources if we wanted, and to be more accurate than I am, but it moves that one up as a very meaningful measure to use, because there's a research base to say this is going to have long-term outcomes on effects on children.
Yeah, because it's definitely, there's plenty of research to show, and there's also a lot showing evictions or multiple moves really affecting households. But I would say that rent burden, that severe rent burden, is sort of an indicator of those things happening. People not, being evicted or being forced out or having to move multiple times because of this severe housing burden. So all of those things are really tied to health outcomes, education outcomes, et cetera. So I think that's what I would. That's what I would probably recommend using.
That sounds very positive to me.
Do you collect any
and we could get it from
state level housing data?
Yes, we have lots. We just put out our statewide housing plan, which actually has a lot of it right there in the plan, in our appendices, and then we have it as well, and we'll be updating that regularly.
Okay, is that online?
We use that in a number of our scoring for applications, for all these kinds of different things. So the state plan is online on our website, and I can send a link to it. But I could also, some of that data is actually already, just because we've been working on this plan for a year and a half, and so the data is already old. So we'll be working on updating a lot of that in the coming months.
Tom, do we want to get a sense of the group? I don't know how many of us are left, but of using housing rent burden. It's a housing rent burden over a certain level, isn't it, Megan?
Yeah, I would say we'd probably want to use the severe burden, so that's 50%, half of income. And then I don't know if you'd want to. So a couple of things to think about too is, I think you'd want to look at households with children. Is that accurate? And would you want to focus on lower income households or look at households overall? Because there are cases of higher income households spending a lot of their income on rent, but not necessarily being, at risk of homelessness or any, they've just chosen to sort of spend a lot on housing. So I don't know if in other measures you're kind of focused on a particular income group or not.
Well, I think our principles are to do population as a whole.
Okay.
But then certainly there are cases in which we are deciding that the policy interest is a subgroup, but we certainly are interested in families with children.
Right, okay.
This is Sarah. Do we mean families with children of any age or families with children of a certain age?
Yeah, I was just thinking the same thing. Can you, the way we're trying to use what the agencies are already reporting so that this dashboard is feasible and is, because it's not budgeted. And so, do you do it all children under 18, or do you break it out?
We've done it both ways recently, just because of like work on the children's cabinet, looking at 5 and under. I would say that for our long-term goals, we're probably going to be looking at all children, 18 and under is sort of my guess on where we'll be going.
Okay. I don't know. This is, I think we want to avoid asking agencies to do special analyses. Yeah. Although clearly families with children under 5 are the group we're most interested in.
Okay. Well, I'll have to check in with let me kind of find out, because honestly, I think we're going to have to be doing different analyses for families with children as well. So it may be that we want to do both of those breakouts. So I'll sort of check in to see where we are here and what they want to be looking at for some of our upcoming potential new programs. And I'll let you know. But it would be possible to do both. So we could do that if that's
okay.
And you did say that you also wanted to do that by race and ethnicity, correct?
Yes, we do.
And do you have particular ways that you are defining or, looking at race and ethnicity?
Again, Tom, it seems to me we're dependent on how the agencies are defining, and they're not the same.
Right, I'm sure.
Tom, I mean, we're not talking about telling the agencies how they have to define race, ethnicity, is it? Are we?
No, it's agency defined, although a lot of us use similar or the same categories, or they can be rolled up to the same category.
Right.
Any other questions for housing? Housing questions? Were you able to look these over? Did you have any comments on?
No, actually, I was going to circle back with Catherine and see where we are.
Okay.
Catherine's not on the line.
Okay, let's see. Why don't we move next to a review of the last presenter we had from EIECST. And I have a handout for that we'll bring up. And if you can recall last time, they have 2 primary outcomes that EIECST uses in their official measures. One's the kids who substantially increased their rate of growth, and the second is functioning within age expectations at exit. Those 2 outcomes are measured for 3 different domains: social emotional skills, knowledge and skills, and meeting one's own needs. And then for each of the 2 groups, early intervention or early childhood special ed. So that gives us our 2x3x2 table, which I've represented there, and then just kind of described all the different combinations. So I guess our options are, we can report on a full set of 12, all 12 measures if we feel, checked all the boxes. We could look at only a single outcome if we think substantial increase in the rate of growth is much more important than functioning within age expectations at exit. The difference there again was that some kids enter already not too far behind age expectations, so they might exit at age expectations but not be considered to have substantially increased. Or we could look at a single age group or a single domain or any combination. I thought all 12 measures would be difficult to report.
I think we'd lose people.
would lose people. I think both early intervention and early childhood special ed are important. These are just my opinions because of the different age groups. And so, at least, you know, I would be down to my choices of looking at both age groups and using one of the outcome measures for all three areas, or looking at both outcome measures for one area like social emotional skills.
Okay, I'll just throw out mine would be to focus on social emotional, use both age groups, and only increase their rate of growth. So other people will weigh in?
I think I intuit the logic behind this, but it just might be helpful to articulate the principles guiding you in that, Bobby.
Oh, okay. So I chose social emotional because when you look at our overall set of objectives, it has risen as a priority. So I see it, and it communicates more clearly. And okay, so that was one. And the second was, I think we need both age groups. They're really different. And then the third is that it seems like from what we were told last month, that increased rate of growth is a more meaningful measure. And that way we would have we'd have a manageable and meaningful. Okay, that was my thinking, David. That doesn't mean I think I'm right. I mean, it's just how I thought about it.
No, they seem to be intuitively, they made sense, but I just thought it would be good to have how we were thinking about it.
So what does other people think?
Logically, yeah, so this is Sarah. That makes sense to me logically, and certainly the social emotional piece aligns with what we were hearing from the work group working on the health aspects of kindergarten readiness measure. But I do have a question in terms of possibilities, and I suspect I know the answer, but I have to ask. Is one option, and if it's what you articulated, I'm just getting it, but is it possible to use the same denominator, so like substantially increase their rate of growth, and you only, in your percentage, they have to meet all three to be counted, right? So you'd look at a kiddo, and if they social emotional, knowledge and skills, and meets their needs, so it's all three of them would be that they substantially increased. Is it possible to do it that way?
I would imagine they could. I don't.
But it does create an extra one.
And then it wouldn't align with how they're doing the measurements, if I remember correctly from last month's presentation.
The other thing was, in the presentation, I'm going from memory, didn't they show that the rate of growth varied substantially across the three domains? Do I remember that correctly?
I think you're right, yeah. So given that, the proposal that you put forward, Bobby, makes sense to me, but this is not my area of expertise, so I'm interested in what other folks think.
This is Alicia. I agree, and I like those. I like what you're saying, Bobby. My only question was about the ceiling. I recall, and this is me going from memory again from last time, I recall that the percentages of kids who were high up on the increase in their rate of growth, that was higher than those functioning with age expectations at exit, so that if we were interested in changes over time, that there might be more room for movement upwards over time. But I'm not sure I'm thinking about
growth or ages?
For age at exit. And I'm not saying that I like the age at exit, because I don't really, but but I'm just raising it as something that I'm remembering thinking last time.
That there's more, the big advantage would be there's more change, opportunity for change over time?
Yes, exactly. And again, it's just me raising it as a thought, and I actually would rather not go with the age at exit.
I'm not being a, I would go with the increased rate of growth as opposed to the age of exit. I know we're probably reducing the amount of growth opportunity you have, but I think it's more appropriate. That would be my case. And I also
So Bill, how about number of domains, or which domain?
Or in terms of social, emotional, and knowledge skills, meeting our needs?
Yes, yes.
I'm okay with the 3 domains. The ones that you...
You'd go with all 3, and then we'd have 6. Is that correct?
Yes, absolutely.
Okay. Okay.
So that would be option B1 I'm looking at.
Uh-huh.
Would that work with you?
Well, I think 6 is a lot. So that's why I was trying to get to one that was a priority, but I think that's a group discussion. Wow, Tom and David, you're looking at it as a whole?
And Bob, it goes back to your question earlier, was the sort of discussion that I said that we should have for later on parsimony.
Oh, okay.
But that being said, I have to agree that 6, even with a generous scope, 6 seems a lot.
It's pretty ambitious.
Yeah, particularly since it's all in one, both area and sector, both,
Although, I mean, one thing to consider is that the state rate is already at 85%, if that makes a difference to anybody.
On social emotional. That's Alicia's point.
The number of early intervention kids who substantially improved on social emotional skills.
How does that compare to the others?
It's 85%, and the others 62% and 74%.
What is it for functioning within age expectations at exit?
It's 42%.
For social emotional?
Yeah.
What do you have the others? Sorry.
And those numbers are lower.
Lower than 42?
Yeah, 34.
So I think it speaks to your area of tremendous area for room for growth. Mm-hmm. But is that really an indicator we want?
That's a good question.
David, were you thinking we get this far and get our ideas on the table and then wait till we go back to that criteria conversation and look at this again? Or are you thinking we should try and narrow it down today?
I think we should try. I guess my instinct would be to try to narrow it down a little bit today, because I think, this is just one objective, and so we're still going to have too much, even if we narrow this down. So yeah.
So which ones do we think about whittling?
Well, this is whether we're going to do 6, which of these options?
I mean, one other option is if we feel like we're sort of torn between, is we can always send it back to, and say, like, if you were to choose one of these three for the dashboard, what would your preference be, and to defer to the judgment of the data owner.
So just slightly different than that. How about we say, this is, we're being challenged in trying to narrow this down, but there's a limit to how many indicators. And so we would value your input on domain and of the two. Don't give them the decision, but ask them to tell us. How's that? It's only a tweak to what you said.
Okay. It's a friendly amendment that I accept.
Thank you. Yeah, that might help us.
But I also think that's consistent with the spirit of as much buy-in from the folks who own the.
Yes. Yes. Absolutely.
I really have to find out.
Yeah, okay.
It's okay. I texted, let him know I was running a little late.
Thank you.
Later, bye.
Bye.
Should
So
we
how
plug-
many people are left in the room, Tom?
No,
Sarah?
Sarah?
Yeah. So I think the question that Tom had was, do we want to try to plug through a little bit more? Does this feel like a good breaking point for this month? So leave that to the
I'd like to make a suggestion. How's that?
Okay.
That we break for today. I do more prep and I actually get out homework this month and we tell people to be prepared.
Yep, I like it.
Okay.
Homework assignments to each of us?
Yep. Your homework's coming.
Okay.
And I also apologize. I was present but not fully present today, so I apologize for that.
What do you think, Bobby?
Oh, I'm having technical difficulties. Okay.
All you have to say is we're adjourned.
And a cold, so you're
Okay.
excused.
Okay, thank you. Okay, thank you, everybody.
Okay, bye.
Thanks, Bobby.
Bye-bye.